and welcome to another Top Doctors online interview where we speak to one of our leading specialists. Today, we're very privileged to be joined by Dr. Mark Rosenthal, a highly respected consultant respiratory paediatrician, to discuss a very important area, which is asthma and its dangers, which are unfortunately often dismissed. So welcome, Dr. Rosenthal. Thank you very much for joining us today. Would you like to introduce yourself and tell us a little bit about your background and your areas of expertise?
Hello, my name is Mark Rosenthal. I'm a respiratory paediatrician. I specialise in all aspects of respiratory disease, including sleep medicine, and inevitably asthma, being very common, is a key part of my work. I see patients at 77 Wimpole Street in central London.
Thank you very much. So we're delighted to have you with us. And as I mentioned, we are going to be discussing the topic of asthma today and why it is so often dismissed when it can actually be fatal.
Well, I think the problem of why it's dismissed when it can, albeit rarely in children, be fatal is that it's very common. 20%, 1 in 5 of all children have asthma at some point during their childhood. And of course, most are mild, truly mild, and very easy to treat. And deaths from asthma in children are very rare, but obviously devastating. There are about 12 to 15 children who die each year in the UK from asthma. And therefore, parents are very unlikely to hear about fatalities. And a bit like snoring, everybody thinks, well, everybody snores, but it isn't normal. And therefore, that's why, in my view, people become complacent about it.
Thank you very much. So to continue with that, could you explain what is actually happening inside the body of a patient with asthma?
Well, the large, but especially the small tubes of the lungs are inflamed for varying reasons, and the muscles around the tubes contract because they're irritable, and this combination makes the airway smaller and harder for air to move, particularly out of the lung, but also to an extent into the lung. And these things are made worse, as is well known, by colds and viral illnesses, exercise, stress, we mustn't forget stress, and specific allergens, most commonly cats, tree and grass pollen, and molds.
Thank you, Dr. Rosenthal. So to continue, how does it actually become fatal? What is the process?
Well, this is quite complicated, and of course, it can't be absolutely proven in a child or indeed an adult because you can't do research about death in asthma. However, the blood flow to the lungs that collects the oxygen and gets rid of the waste carbon dioxide needs to be matched to the areas of the lung that are being ventilated. And if areas of the lung are not being ventilated, blood is diverted away from those areas to areas that are being better ventilated. But of course, there's a limit to how much you can push around the blood flow in the lungs. And you'll get to a stage eventually of where you aren't getting oxygen into the bloodstream, and that can become an increasingly vicious circle. And that is a mechanism, it is thought, by how people die. Now, the other way that it can occur, is a very practical point, is the use of salbutamol or Ventolin, which is an absolutely standard treatment for the relief of symptoms, in an air-driven nebulizer. And I do want to emphasize the word air-driven. The effect of that, if you give salbutamol in that set of circumstances, is to suddenly increase ventilation in those areas that were not being ventilated and which had very little blood supply. So the paradoxical effect is that you actually make matching much worse, and you can, under special circumstances, precipitously drop your oxygen saturation. You can see this all the time in accident and emergency departments, that even if you give a salbutamol nebulizer via an oxygen-driven nebulizers, which is what all hospitals do if they use a nebulizer, you will see a transient small drop in oxygen saturation, which will then come back up again. But that is because you're using an oxygen-driven nebulizer. And one of my roles is to sadly examine the sequence of events that occur in some children who have very sadly died of asthma. And it is often the last thing that happens before they collapse and effectively die is that they use either a borrowed nebulizer with salbutamol or their own that they should never have had, but I have had instances of it being bought or prescribed in other countries around the world and brought to the UK. And this is disastrous. And I never, ever prescribe salbutamol via a nebulizer for use at home. It must not happen.
Thank you, Dr. Rosenthal, for explaining that so clearly. So to move on to our next question, there are obviously real dangers related to asthma. Is a lack of effective treatment the only factor in this, or do some people carry a higher risk of serious asthma complications?
Well, the question implies that there isn't an effective treatment for asthma. The Children's Problem Asthma Team, of which I was a member for quite a few years, has been investigating and treating children with this problem for 25 years now. And in my opinion, there are very effective treatments for asthma. But the Royal Brompton team have demonstrated repeatedly that not taking the preventative inhalers regularly is easily the commonest barrier to effectiveness, even seen not infrequently in children who are sufficiently bad as to require intensive care admissions, which personally I find absolutely incredible. Indeed, in a study where the families knew that the inhaler had a computer chip in it, because we told them, that would record every time the date, the time, and how many puffs were used, only had about a 60% usage rate from what the prescribed prescription was. And even more incredibly, even those who collected 100% of the prescriptions from the chemist that they were supposed to get, the actual usage ranged from 20 to 90%. So I dread to think how little is actually used if they didn't know that there was a chip in the inhaler recording it. So over time, it has been found, and this is another paradox, that it isn't necessarily the most severe asthmatics who are at risk of dying. It was the ones, paradoxically, that were relatively mild. Now, how they became designated as mild may have been either by the patient themselves or their families, and that was either decided incorrectly, or people get so used to symptoms all the time that they regard them as normal and don't realize how affected the child is from their asthma. The team, over the period, as far as I can remember, have had 2 deaths from asthma. One had a mother who was a barrister who absolutely refused to use a steroid preventative inhaler despite numerous written warnings, and their child died. And the other was indeed a very severe asthmatic, but with a lot of other social and psychological issues, including not taking the treatment. There are other factors, of course, having pets, especially cats, social chaos, smoking at home, other psychological stresses, etc. But another common finding, which I find quite upsetting, is that children, and I'm saying from aged 8 onwards, are often expected to organise and take their own treatment. I am 65 years old. My wife would not trust me to tie my own shoelaces without supervision. So having children being told to do their own treatment is, in my view, a recipe for complete failure. So I always say to my patients that inhalers have to be taken within 1 meter of your nose with you looking at them. And if children, as they often do, come downstairs or come out of the bedroom and say, Mum, Dad, I've done it, I don't care, you're doing it again. Because it's not that I don't believe you, Mr. or Miss, I don't believe anybody. It is a valid discussion point that not using preventative inhalers, at least 80% of the time, could well be considered a child safeguarding issue.
Thank you, Dr. Rosenthal. Really, really interesting and surprising also. So effective management is clearly very, very important. What is the best way to control asthma in children?
Take the treatment every day, twice a day, and adult carers supervise it irrespective of age. Don't get a pet cat, don't smoke indoors, and that will deal with the great majority, but not all, of the issues. I'm a great believer in the acronym KISS, which means keep it simple, stupid. One example of which is that I wrote an editorial saying, never mind the fancy biologics and all that you might read in the newspapers of progress, just take the inhaler.
Thank you very much. And finally, Dr. Rosenthal, how does management of the condition evolve as a child with asthma grows up?
Personally, I don't think, as I only deal with children, I don't think things should change, particularly as they grow up. No adolescent likes doing treatment, however simple, and in numerous studies over many chronic conditions, be it diabetes, asthma, cystic fibrosis, rheumatology, or even cancer maintenance therapy, average adherence to any chronic medication regime is 50%. Doesn't matter what it is, it's 50%. So parents and everyone is different and every child is different. So parents and health carers have to try and tailor things to that individual as far as possible. But adherence, or there are many other terms used for it, concordance, etc., is, in my view, the single key issue.
Thank you so much, Dr. Rosenthal, for sharing your expertise on this really, really important topic. And I'm sure it's been really informative for parents of children and young people, and indeed anyone who's affected by asthma. I'd like to remind anyone who's concerned about their child's asthma symptoms or management that they can schedule an appointment with Dr. Rosenthal by visiting his Top Doctors profile. Delighted to have spoken to you today, Dr. Rosenthal. Many thanks again.
A pleasure.
Thank you very much.